Thank you for attending another one of the weekly webinars from Just Us Retirement. Um, I am Tabitha Justice. I'm the owner of Just Us Retirement, and we have Stacy with us today. Stacy is one of the agents here at Just Us Retirement. And just to tell you a little bit about us, if you've never worked with us before or know our story, we are what's considered a collaborative and education-focused retirement company. So we love education, don't we, Stace?
Oh, yeah.
So you'll see that's one of the things that we're really known for is for the educational content that we put out. And today our topic is Part D, prescription drugs. And how we're going to do this is Stacy and I are both going to role play a little bit with questions that our clients have. Because Part D is really confusing,
Oh, yes. Very confusing.
Yeah, and so we're going to try to break that down. And before we get too far into this, we want to really put out a warning that everything that we're talking about in here ends on December 31st of 2024, and it is completely different rules for 2025, right?
Absolutely.
So that's one main reason we wanted to put this out now. We want to make sure people understand how the current rules work and then how the new rules are going to work. And we have 3 more webinars planned. So keep an eye out about the Part D changes for 2025. So we're going to first start with terms that everybody needs to know to understand how it works. The first one, I feel like this is one that most people will know, but just in case, formulary. It all comes down to formulary. So formulary means it's a list of medications that are covered by your prescription plan. And formularies are tricky because there are dozens of plans on average, 40 different Part D plans. And then when you add in Medicare Advantage, each person has access to about 80 different plans, and all 80 plans have different formularies. I feel like one of the most important things to know about this is, Stacey, I know you and I come across this a lot. Everyone just thinks their medications are included, but it is actually each plan is required to cover 2 medications from each class, from each tier class. So that's really important because not all medications are going to be covered, which is something that we're going to go over. Any questions there? Are you good?
All right. I'm good.
Okay. All right. Pharmacy benefit management. This one is really ultimately what controls everything about Part D. People get mad about the insurance company or the pharmacy, but it's actually the pharmacy benefit manager. And I would say 99% of people have no idea what this is. So the benefit management is like the middleman. So they're the ones who actually make the decisions between the health insurance company and the pharmacy about what medications they are allowed, the pharmacy is allowed to offer, and what the insurance company is allowed to offer the pharmacy, and then how much each of those medications is going to cost. I don't know that there's much to say about this one because most people have no idea what this is.
Yeah.
But this is ultimately who is making the decision. It is not your insurance company. It is not the pharmacy. It is the PBM. All right. I'm going to let you go through these, Stace. Would you like to talk about these 3 terms and what they mean?
Absolutely. So a copayment is a fixed amount that the insured person pays out of pocket for a prescription medication covered by their plan. For example, a plan may have a $10 copayment for generic drugs and a $30 copayment for brand name drugs. A deductible is the amount the insured person must pay out of pocket for covered prescription drugs before the insurance plan starts sharing the costs. Once the deductible is met, Co-payments or co-insurance may apply. So next is co-insurance. Co-insurance is a cost-sharing mechanism where the insured person pays a percentage of the medication's total cost, while the insurance plan covers the rest. For instance, a plan may have a 20% co-insurance for a particular drug, and the insured will pay 20% of the drug's price. We are seeing more standalone prescription drug plans electing to have a percentage copay versus a flat copay. This can significantly increase a client's out-of-pocket cost for that medication. So copays are flat amounts that you pay for the prescriptions. Co-insurance is a percentage that you pay.
I think this confuses people so often.
Mm-hmm. Yeah.
They expect co-payments. They expect, regardless of when they go into the doctor or to pick up their pharmacy, that it's going to have a co-payment. And kind of like what you said, and especially for 2025 with the new plan changes, a lot of them are shifting to a co-insurance, which, as you said, is like 20%, 30, 40, 50% of whatever the price is. So I feel like a lot of people get really upset when they find out their medication is a co-insurance instead of a co-payment.
Mm-hmm.
And I think deductible is another thing that a lot of people get confused on. So not all drug deductible or not all drug plans have a deductible, but if it does have a deductible, so many factors play into this. Usually tier 1 and tier 2 medications are not in the deductible stage. Usually those are just offered to you at no cost. If, and here's the stipulation, if they're going to preferred pharmacy. If they're not going to preferred pharmacy, then you have to check with them, because sometimes those will count towards the deductible and you have to pay for them. I feel like we get a lot of people upset about this too. So they don't understand when we ask you what pharmacy you're going to, it actually really is important that you go to the pharmacy that you tell us that you use. And if you switch pharmacies, to let us know so that we can check that for you, because it can be significant price difference.
Yes, absolutely.
All right.
And just because a pharmacy is in the network with your drug plan doesn't mean they are automatically a preferred pharmacy either. So people get mixed up on that too.
Yeah, that's such a big one. So you have in network, out of network, and preferred. Preferred is always going to be cheaper medications, like less expensive medications, than just a regular in network or an out of network.
Yes.
All right. Generic drug. I feel like this is another one. Most people understand what generic is, so I don't think we have to spend a lot of time on this, but generic just means that basically the patent has gone away on a drug and they're able to give you the same basic formulary to create the drug. It's just going to be at a cheaper name or a cheaper price than a name brand drug. And then we have brand name drugs, and brand name drugs it belongs to the people that originally created the drug, and they have a patent on that drug and on that name. And that's usually why they're more expensive than a generic medication.
And the patent is for years.
Oh yeah, that patent can last for a really long time.
I want to say it's over 10 years, but I can't think of the exact number right now.
Yeah, I mean, some of the things that they can even do with those medications when the patent is starting to expire is they can tweak it just a little bit and add a small extra little compound, and ta-da, it's a brand new drug and it's back to being a name brand drug. So yeah, there's little tricks in there.
And then you have to wait even longer for a cheaper generic to come out.
Yeah, and while we're on this topic, even sometimes when it's a generic drug that comes out, sometimes the insurance companies still won't pay for that generic drug because they have an agreement with the name brand drug. So sometimes people still get left out then.
Mm-hmm.
Drug stages. So we're going to go into this a little bit more, but almost all drug plans, not all, but almost all drug plans have what is considered a deductible stage. For 2024, it is $545. So that means you have to pay that amount when before the plan pitches in to help you cover the cost. But as we said, often if you're going to a preferred pharmacy and your medications are tier 1 and tier 2, often you can skip this deductible stage, and it's only going to apply for tier 3 and above.
Mm-hmm.
But you have to be
and out of
pharmacy.
out of standard pharmacies as well.
Mm-hmm. Yes. Okay, so then we have the initial coverage stage, and this is where we talked about, this is where you enter into, you're either paying the copay or the co-insurance amount, which is increasingly, as we said, and this is going to be especially important for 2025, it is going to transition into more co-insurance than what people are right now used to. It's going to be a lot more co-insurance and less co-pays. And for the rest of this year, we do still have a coverage gap, which is commonly referred to as a donut hole, but the donut hole is also going away next year. So for next year, there's no coverage gap, there's no donut hole, but some of you may be stuck in it for this year, for 2024. Hopefully that will change for next year. As of this year, there's no more catastrophic coverage. You pay $0 once you hit the catastrophic coverage. And then, of course, that will be the same next year also. There's going to be some changes where the max out of pocket is $2,000, but we're not there yet. Oh, I skipped a page. All right, so going back a little bit to those tier levels, we have tier 1. These are going to be your preferred generics. Then we have tier 2. These are still generics. They're just higher cost generics. These are sometimes what's referred to as like name brand generics. They're still generics. They just are popular and more expensive to make. Then we have tier 3, which is a preferred brand name. So these are the ones that are most requested, and they are also brand name. They do not yet have a generic equivalent or a generic that is on the market yet for people to purchase. Then we have tier 4. Tier 4 is a non-preferred. So this is not going to be the first choice that your doctor or insurance company wants you to go to. They're going to want you to use tier 1, tier 2, or tier 3 instead. Preferably tier 3, since this is going to be a name brand medication. Then we have tier 5, which is specialty. This is the most expensive that you can get. And it's not listed on here, but some also have tier 6. It's not good for your pocket.
Mm-mm.
Tier 4 and above.
No.
Yeah, you want to try to, if at all possible, keep your medications tier 1 and tier 2 and potentially tier 3. Those are, the higher up you go, the higher your medications are.
Yes.
Anything to share here? You good to go on?
I don't think so. I think we can go on.
Okay. Prior authorization. This one affects people a lot at the beginning of the year, like January and February. A lot of people get upset with prior authorization. We get a lot of phone calls from that January and February.
Yes.
So some medications require something that's called prior authorization. This means, and this is, I think, what confuses people. They're like, it's on the formulary. We checked, it's on the formulary. It can be on the formulary, and you still have to have a prior authorization. So, what that means is your doctor or the PBM, the pharmaceutical benefits manager that we just talked about. But it's usually your doctor has to approve, like say why that medication is so important and why you need that one over a less expensive medication.
In a lower tier.
Yeah. So we're going to go through that a little bit, like how does the prior authorization process work? And it's a little bit of a complicated chart, but Stacey, I'm going to pretend like you are my client, okay?
Okay.
All right. So, Stacey, it's the first of the year. You're on a new plan. You need prior authorization for a medication, but maybe you don't know it yet. Maybe you're just going to pick up your medication. So you go to the pharmacy, they're going to run the medication through, and then they're going to get a notification back that says, wait, we're going to reject this because we need a prior authorization from her doctor to go through it. So the pharmacy notifies the doctor, and they're going to say, hey, we need you to complete some forms, authorizing and explaining why Stacey needs this medication. The doctor is going to complete the paperwork, and then they send it in back to that pharmaceutical benefits manager. And that middle person, I feel like this is so important. It's the pharmaceutical benefit manager that approves it, not your pharmacy. Don't get mad at the pharmacy. Don't yell at them. It's not your insurance company. Don't yell at the insurance company. And it's not us. It's
No,
not
it's
your
definitely
agent.
not us.
Please don't yell at us. We realize it's frustrating, but it is the pharmaceutical benefit manager that approves it or not. So they then have the pharmacy tell the patient whether or not that it was approved, and they will say, hey, Stacey, as of this moment your medication is not approved. Do you want to wait for it to be approved, or do you want to pay out of pocket for it? And in my experience, most people, if it's like, not too expensive, they just say, I'm just going to pay out of pocket the first time.
I've done that myself.
I have too. I've done the same thing. If it's not super expensive, I'm like, I don't want to come back. I'm just going to pay for it today. But can you start the process so that next time I come back, hopefully it will be approved? So if the patient pays out of pocket, here's kind of like the trick to where it comes down is, for the most part, once you pay for that, it is really hard to get the money reimbursed to you. So even if the plan approves it, the easiest thing to do is, if you're going to want the plan to pay for it, don't pay out of pocket. Just wait for it to be approved. Instead of paying out of pocket and then trying to file a reimbursement, it's most likely not going to happen. So let's go back. Let's say we're going to go back over that to where we're waiting on the PBA to approve it. And they say, Stacey, do you want to pay out of pocket? And maybe this is like a very expensive medication. And Stacey is like, nope, don't want to pay out of pocket. I'm going to wait for it. And then she has the option to wait and see if they approve it. If they don't approve it, you can appeal the process, or you can just try to talk to your doctor about switching to a different medication. If they approve it, then you're able to run it through insurance, and your insurance is going to pay for it. And then, Stacey, you can go pick up the medication. This trips up a lot of people.
Yes.
Yeah. And I think a lot of times like I said, they get really angry because, hey, it's on the formulary. We're aware it is on the formulary, but there's extra steps. And then they get mad at the pharmacy, or the insurance company
Or
or
us.
us. If you've never researched pharmaceutical benefit managers, it's something interesting to research. That's where a lot of these fights come in place. Okay, so here's another way that they're trying to limit cost, because they're trying to limit the cost with the prior approval. So the prior approval is usually safe, as you know, it's for a couple of reasons. One is because it's a really expensive medication, or it is maybe something that has a lot of side effects, and they want to make sure, like, is this really the best medication, because it's going to have XYZ side effects. But it's often a lot of times too to lower cost, and these are also ways to lower cost. Do you want to go over these?
Yeah.
Okay.
So step therapy is a utilization tool that requires you to first try another drug to treat your medical condition before they will cover the drug the doctor may have initially prescribed.
Mm-hmm.
If the doctor writes for drug C, the plan can make them try and fail on drugs A and B before approving drug C, because A and B may be a lower tier, lower cost medication.
And we see that a lot, right?
Mm-hmm.
Like,
they want you to try something more inexpensive first to see if that will work before they'll allow you to bump up to something more pricey.
Which is, again, why people want to be careful switching plans, because once you have a prior authorization or a certain medication approved, it doesn't mean that's going to transfer to a new plan.
Right.
You may have to start all over. And even if you stay on the same plan, you may have to start all over again anyways the next year or two. So that step therapy could be something that annoys some people.
Mm-hmm. Mm-hmm. And people don't understand it.
Yeah.
And then quantity limits is a management tool designed to limit the use of selected drugs for quality, safety, or utilization reasons. Limits may be on the amount of drug that will be covered or the duration of time they will cover the medication. So for something like pain management medication, they may only cover up to, say, 14 days worth of medication.
Mm-hmm. Yeah, and I think this one can be a difficult one, because maybe every single one of your medications is on a 90-day refill, except like a pain management. And people find that really annoying,
Mm-hmm.
to where they're like, well, I have to go to the pharmacy every week or every 2 weeks or every month just for this one medication. Or maybe all their other medications are on mail order, but they can't do like their pain management on mail order because of quantity limits. So this is another one of those things that can be frustrating. But again, they do it for a couple reasons. They're either going to do it because they're trying to lower cost, or they're going to do it because of the side effects. And like in this case, the side effects could be like potential addiction issues. So, all right. Transitional fill. So this one is also one that I think confuses a lot of people. I don't find this one to be as big of an issue, but this is often, either someone tried to self-enroll into a plan, or they had a bad agent that enrolled them into a plan, or the person didn't properly inform their agent of medications. Now, that one we've come across that a lot. They're like, well, I don't take that one that often, so I didn't tell you about it. We have to check every single medication. So when you start a plan, let's say, Stacy, let's say that I'm on a medication and I don't take it that often. I only take it when like I have an outbreak of something, or I have a really bad migraine, and I'm like, oh, I don't need to tell Stacy about that one.
People do that often with inhalers or creams.
All the time with inhalers. Mm-hmm. They're like, well, I just don't take it that often.
Yeah, I only get it filled like once or twice a year, so I didn't think to tell you.
Right. And so what happens with that is the plan is only required to fill that medication one time. And then you're kind of out of luck if you can't get it approved in any other way. So, this again, going back to the pain management, this could be a pretty big deal if you're only allowed to get like a week's worth of medication at a time, because they will only give you that week's worth of medication. That's your one time transitional fill. And then you got to figure something else out. You got to either switch medications, or you have to ask for them to do a plan override for a different medication.
Or in this scenario, could they pay cash?
They can. Yep. Good point. So we see that sometimes too, especially if it's not an expensive medication, like just pay cash for it, use a coupon card, like use something else for it. But if it's a very expensive medication, some of those creams can be like hundreds and hundreds and hundreds of dollars.
Mm-hmm.
So, okay. So the rules for a transitional is, so it has to be, I'm getting it all confused here, sorry. But the rules for the transitional is kind of like what we already went over. It's only for the first 90 days of the plan. I didn't say that. However, it also goes down to whatever the prescription says. So if it's a 14-day, if it's a 30-day, if it's a 1 week, it'll only be one transitional fill. So that can be really bad if you only get a 7-day refill and then you're kind of past your transition. You don't even get the full 30 days. So like if you're in the middle of a migraine and you only have like a week's worth of medication, but your migraine goes into week 2, or you have another one right away, you still have to go through the approval process to get a different medication covered or to get that medication covered. And I would say like we don't see this a lot, but it is a massive pain when it does happen. Yeah. Okay, so how do you go through the drug stages? So we kind of went over this earlier, actually. So you have your deductible phase, and this is where you have to pay a certain amount before the medication counts, or before the plan starts paying. So as we said before, Tier 1 and Tier 2, if you're at a preferred pharmacy, you usually don't have to enter the deductible phase. Tier 3 and above almost always do. I do think it's an important thing for people to realize is you don't necessarily have to pay it, just someone has to pay it. So that can be a charity, a grant, it can be lots of different programs. It just has to pay. What does not count is what people use a lot of. You cannot use a discount card. You cannot, if it's not on your formulary, you can't pay cash and expect it to count. It has to be on your formulary, and it has to count towards the medications on your formulary, if that makes sense. Makes sense? All right, then you have the initial phase, and this is what we were talking about earlier. This is if you have a copay, which is a flat rate that you pay, or a co-insurance, which is a percentage that you're going to pay. So right now, the initial phase for 2024 is $5,030. That changes a lot next year, right? It's going to go down to $2,000. But again, we have a webinar coming out about all of that. Coverage gap. This is once you hit that $5,000 right now is the coverage gap, or what some.
And that 5,000 is what you and your plan pay together until you hit
Right.
5,030.
Yes. So that confuses a lot of people too, because they think, oh, I have to pay $5,000 and then I'm in the donut hole. Or no, this is the total cost of the drug True out of pocket is what it's called. So troop, this is like what is paid as you move through. So let's say you have a medication that is $500. Your copay for that medication is $10. $10 is not the true out of pocket. It's the full amount, the $500. So I think a lot of people get scared when they first hear the coverage gap because they're like, I have to pay 5,000. And yeah, that's not what that means. All right, so we kind of just went over this. So what counts towards troop? And this is what's on your formulary and then what has been paid. So if this means if the drug manufacturer paid a certain amount, if your insurance paid a certain amount, if AIDS assistance, the Indian health system, charities, HSAs, FSAs, MSAs, extra help. There's all these programs that count towards the troop. It's not just what you're paying. But I want to emphasize again, it has to be on your formulary or be approved to count. So you can't just like go to the store and pay cash for a bunch of medications, not run it through your insurance company and then say, but I paid this much amount of money this year on medications. It has to go through your insurance company and be on that formulary.
Yes, for it to count toward the troop.
Mm-hmm. Insulin savings program is really cool. Do you want to talk about this one or do you want me to talk about it?
Yeah, I can.
Okay.
The insulin savings program caps cost sharing for each insulin covered under a Medicare prescription drug plan at $35 for a 1-month supply. Mm-hmm. Part D deductibles will not apply to these covered insulin products. So you don't have to worry about paying a large deductible for your insulin at the beginning of the year.
Which used to be a really big deal.
But, and this is where people get hung up a lot, your particular insulin has to be on your plan's formulary for that $35 cap to apply.
Mm-hmm. And just as a reminder, Stacy, like when it comes to that insulin, PBMs, those pharmacy benefit managers are not required to cover all insulins. So like people have to check to make sure their insulin's covered. I think people just hear $35 cap and they're like, all insulin. No, mm-hmm. You still have to make sure it's on the formulary.
Yes.
Yep.
And if your plan participates in the insulin savings program, you will not pay more than $35 for up to 30-day supply for select insulins that are on the formulary through the first 3 payment stages. So the deductible phase, the initial coverage phase, and the coverage gap / donut hole phase. Mm-hmm. The insulin savings program does not apply to the last stage, which is the catastrophic stage. Although your copay will be fixed at $35 for a 30-day supply during the first 3 stages, the total cost of the medication, which is what you pay and what your plan pays combined, does get counted in the accumulation of dollars spent. Therefore, this will move you through the stages and into the coverage gap and then into the final stage, catastrophic. Once you are in the gap, although the price of your insulin doesn't change, your copay for all other medications will change, and that is in the donut hole.
This is very complicated for some people to understand because when they think of the donut hole, they think that this means they have spent thousands and thousands and thousands of dollars and now they're in the donut hole and they're like, no, I only, like my medication was only $35. I haven't spent thousands of dollars, but it goes back to that troop. Mm-hmm. The total cost of that insulin still counts for all your other medications. You're not required to pay more for the insulin, but it doesn't mean it's not pushing you into the donut hole. So I think that confuses a lot of people. So the insulin savings program saves you for insulin, but it's not saving all your other medications too. It's just the insulin savings program. So I don't know. I feel like the more we talk about this, the more confusing it is for people. So we do have several more webinars coming out. So we have a webinar coming up on the 2025 Part D changes. We have a webinar coming up 2025. A brand new program is being introduced where you can make payments on your medications. It's called a medication payment program. And then we also have just like another one that is very in-depth, very complicated, but it is all the other programs that are available to help people save money. Because honestly, a lot of times it does make sense to use a coupon card or like a Canadian pharmacy or a 340B program. There's lots of ways, patient assistance programs. There's lots of different ways to save money outside of using your insurance.
Mm-hmm. We help people with that every day.
Mm-hmm. And that's something that we offer for all of our clients, right? Like we check, is it better for you to use your insurance or is it better for you to use a different program? And I think that's something that if your insurance agent is not helping you with that, maybe look into other insurance agencies, because that's a lot of what we do, right? Is spending that extra time seeing what programs are available.
Yes.
All right. Well, I think that's it for today. Thank you, Stace.
Thank you.
All right. Everyone else, follow us on our Facebook page, Just Us Retirement, and look us up for our private Facebook group where we have lots of conversations and update our clients better. And that is WV Medicare Questions. WV Medicare Questions. Other than that, have a wonderful day. If you have any questions, just email us and we will get back with you as soon as possible. All right. Thank you.